Good morning or afternoon, everyone, depending on where you are joining us from today. My name is Beth Mandel, and I'd like to welcome you to today's webinar. I'm a Senior Managing Associate in the Employee Benefits Practice of Thompson Hine's Cincinnati office. And I'm joined today by Nicole Bitter of Willis Towers Watson. Funny enough, we were supposed to have Ann Richter here with us today from Willis Towers Watson as well, but she actually got pulled into a Mapia emergency this morning. And so that just goes to show the urgency and importance of the issues that we're talking about today. One of their clients got hit with a DOL request and is under a very short time frame. And so Anne is helping out with that. So Nicole, would you like to introduce yourself?
Yeah, no, thank you so much. My name is Nicole Bitter. I am an attorney by background, but function as a compliance consultant at WTW. And again, apologize for Anne not joining. I think to your point, it is definitely stressing the urgency of this topic. So thanks for having WTW support your conversation.
Yeah, thank you, Nicole. And we are definitely happy to have you here today. So thank you very much for taking the time to do this. We will be discussing group health plan mental health parity compliance today, and in particular, the Consolidated Appropriation Act's new reporting requirements. This webinar is the second in a series of 6 webinars. We'll present each webinar on the 4th Wednesday of every month at noon through August. And each webinar is exploring a different CAA related topic, including today's mental health parity topic, and then additionally transparency, surprise billing, and more. Please join us monthly or just for the topics that are of interest to you. You can register through the invitation you received or on the events tab at the Thompson Hine website to just proactively address a question that we often receive. Today's webinar is being recorded and will be sent to all registrants within approximately 2 business days. And during today's presentation, please feel free to use the question panel at the upper right-hand corner of your screen to ask questions. We'll most likely answer questions at the end of the webinar as time permits. However, if we see a question come through while we're presenting, we may get to a few questions during the presentation. And so I'll get started now. It looks like we do still have some people trickling in, but we've got a lot to cover. So let's see. And of course, my screen is all of a sudden not. There we go. All right, so today's presentation. So we're going to provide an overview of the Mental Health Parity and Addiction Equity Act, or Mapia, and the new requirements that relate to Mapia under the Consolidated Appropriations Act. After we go through the overview, then we're going to kind of talk about some practical experiences that we've had in the last year regarding analyses and reporting, and then some recommended action items. So beginning with the overview, what is Mapia and why do I keep hearing about it? So Mapia, basically, I know those of you who work with Kim Wilcoxon from my office or who have seen her speak, you know, we always say that this is basically the nightmare scenario for us. This is what keeps us up at night. And, you know, I don't relish sitting at 2 a.m. and thinking about how are we going to respond to DOL requests, but unfortunately, that's the situation that we're in right now. So mental health parity, the general requirements have been around for a long time. Mental Health Parity Act dates back to 1996, but we really got the beefed up mental health parity requirements that we now are familiar with today with the Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act in 2008. That basically brought protections related to substance use disorder benefits within the fold and imposed some of the additional parity requirements that we're going to be talking about today related to financial requirements and non-financial treatment limitations. So this act generally applies to group health plans and health insurance issuers who are offering group or individual coverage providing mental health or substance use disorder benefits. It doesn't apply to group health plans that provide only accepted benefits. So when you think about accepted benefit, dental, vision, EAP, those types of programs are not going to be subject to Mapia. It also doesn't apply to certain small employers, generally employers with 50 or fewer employees. But most employers are going to be subject to these requirements. And then it also doesn't apply to retiree-only plans. All right, so since 2008, we've gotten kind of a steady stream of guidance from the agencies, in particular the DOL. So we've gotten regulations in 2010 and 2013, tri-agency facts. The DOL has issued a self-compliance tool that plans can use to evaluate financial treatment limitations, non-quantitative treatment limitations. That tool is updated by the DOL every 2 years. So we're actually expecting another update this summer. The DOL has also issued enforcement fact sheets. There have been reports to Congress, and there are additional tools that have been created to help participants request information related to a plan's Mapia compliance. All of this guidance is helpfully available at one location on the DOL's website. And there is a lot of information that can be gleaned from this guidance. So for example, peppered sort of throughout this guidance are examples and sort of red flags of things to look for in your plans that may signal a potential Mapia violation or something that you just want to dig further into. And we'll get into greater detail about that as we go through this presentation. So big picture, Mapia is designed to create parity between medical or surgical benefits and mental health and substance use disorder benefits. Medical and surgical versus mental health substance use disorder, those need to be defined in the plan. And plans have to be intentional about, what they're categorizing certain benefits as. So for example, for a long time, there has been debate about whether, autism is considered a medical condition or a mental health condition. And plans have to rely on certain resources or certain sources in designating benefits and conditions as either on the medical side or on the surgical side. So for example, current version of the Diagnostic and Statistics Manual, that is frequently used to identify mental health substance use disorder conditions and services. Plans in general are not required to offer mental health or substance use disorder benefits. So Mapia doesn't require plans to offer those kind of benefits. But what it does require is if you are offering those benefits, then you have to provide parity. You have to make sure that the plan is in parity between medical and surgical and mental health and substance use disorder benefits. And Mapia basically looks at 3 different categories of parity. So annual and lifetime limits, financial requirements, and quantitative treatment limitations. Those would be things like the copays that are required for medical, surgical versus mental health substance use disorder benefits. Things like, do you have a different deductible? Are there limits on the number of office visits that are applied to mental health substance use disorder benefits that are different from the limits that are applied to medical and surgical benefits? And then the third category is non-quantitative treatment limitations. And that is the category that we're going to be focusing on most heavily today. So non-quantitative treatment limitations are basically any treatment limitation that isn't expressed as a numerical limitation. And so what are some examples? Prior authorization or pre-certification requirements. medical necessity requirements, conditioning benefits on completion of a course of treatment. So, you know, this is sort of similar to fail first or step therapy protocols, right? That you have to, you know, complete the benefit's not going to be provided unless you actually complete the course of treatment. So if you stop part of the way through, no benefits will be provided. Fail first and step therapy, you have to go through a specific course of treatment before maybe the desired course of treatment will be covered. And then prescription drug formulary designs, standards for determining provider admission into a network. That has been a focus of the DOL in the last several years. They've also focused on how plans are determining reimbursement rates for providers. So if the methods for determining reimbursement rates for providers of mental health and substance use disorder benefits are more stringent, or perhaps result in practice in lower reimbursement rates for those types of providers, that could be a red flag. And then determination of usual and customary charges. So these are just examples of NQTLs. Again, the guidance that has been released has, you know, many more examples of the NQTLs that the DOL is focused on. We unfortunately do not have an exhaustive list of what the DOL considers to be an NQTL. And so sometimes, you know, part of the tricky aspect of doing this analysis is just simply identifying what standards under your plan would qualify as a non-quantitative treatment limitation. Okay, so compliance overview with respect to non-quantitative treatment limitations. So ultimately, the focus is sort of on what has been done in the background in deciding to apply the non-quantitative treatment limitation. So ultimately, processes, strategies, evidentiary standards, or other factors that a plan used in applying the NQTL have to be applied to mental health substance use disorder benefits in a manner that's comparable to and not more stringently than when applied to medical or surgical benefits in the same classification. The classifications are important because they have to be called out, they have to be looked at when doing the analysis. And so there are only 6 permissible classifications that the DOL allows you to basically divide benefits into. We've got inpatient in-network, inpatient out-of-network, outpatient in-network, outpatient out-of-network, emergency care, and then prescription drugs. And one of the things that we'll see when we get into the sort of form and format and content of these NQTL analyses is that the DOL is going to expect you to identify whether a particular service is considered, you know, inpatient in network or outpatient in network. And this seems kind of obvious, but there are some services that potentially straddle the line. And one of the gaps that the DOL has identified in the analyses that they're getting is, you know, plans aren't always particularly identifying the category or classification that the benefit falls into. And then additionally, every NQTL has to be analyzed both in writing and as applied. And we'll talk more about that later. So here's an example of an NQTL and what sort of might be looked at in determining compliance. So provider reimbursement rates. Again, this has been a focus of the DOL. So for medical surgical benefits, the plan determines reimbursement rates by reference to the Medicare physician fee schedule. When looking at parity, what we want to see is that for mental health and substance use disorder benefits, the reimbursement rates also have to be determined in a comparable way by reference to the Medicare physician fee schedule. And then any variance in rates applied by the plan to account for factors like nature of service, provider type, market dynamics, have to be applied comparably and no more stringently to mental health substance use benefits than to medical surgical benefits. So if you are varying rates based on those factors for only mental health substance use disorder benefits, and you're not really considering those factors when determining rates for medical surgical benefits, that is a red flag and something that should be revisited. All right. Example 2, pre-authorization, another common focus of the DOL. So again, just to revisit the standard, we're looking at the processes, strategies, evidentiary standards, and other factors used in determining that pre-authorization will be applied to mental health and substance use disorder benefits. So example, a plan utilizes a panel of medical experts with equivalent expertise in both medical surgical and mental health substance use disorder benefits to assess whether pre-authorization is appropriate to apply to certain services based on the factors of cost and safety. The panel recommends that the plan require pre-authorization for ECT therapy because there are high costs and safety concerns associated with that type of therapy. And as we know, ECT therapy is most often associated with mental health care treatment. The plan does not require documentation or studies to support these concerns and instead relies on just established medical best practices. So with respect to proving parity, the plan is going to have to demonstrate that it similarly relies on established medical best practices to define what constitutes high cost for medical surgical benefits and identify legitimate safety concerns with respect to medical surgical benefits. And then we have to be able to show that the plan similarly imposes pre-authorization requirements on medical surgical benefits based on those factors. So if the plan, again, is not really looking at cost, is not really looking at safety concerns when evaluating medical surgical benefits to determine whether pre-authorization requirements should be applied to those benefits, we potentially have a parity problem. Okay, so what are the penalties or the risks of non-compliance? Currently, there is no specific penalty or enforcement rule under ERISA for violations of Mapia, although there have been several proposals in the last few years to beef up the enforcement authority and provide for specific penalties. There were potential penalties that were proposed as part of Biden's proposed budget this year. And so I do think it's very possible that we could see increased penalties in this arena in future years. The IRS can impose excise taxes of $100 a day for each individual to whom a failure relates for a group health plan's failure to comply with Mapia. Thus far, we haven't seen the IRS really imposing these excise taxes, but this type of excise tax is something that actually is supposed to be self-reported by plans. And what we don't know yet is if the IRS is going to increase enforcement and collection of these types of taxes based on the reporting that I'm going to talk about in a moment that is now due to the DOL, and then the reporting that's due from the DOL to Congress. And then so thus far, really, the big enforcement stick with respect to Mapia has been lawsuits. So we've seen participants, beneficiaries, and the DOL using civil enforcement provisions to file lawsuits to enforce Mapia. Plaintiffs' lawyers who bring ERISA lawsuits and are successful are able to oftentimes get attorney's fees. And so these types of cases are very attractive to plaintiffs' attorneys. And then as a result of these lawsuits or as a result of DOL investigations, plans may be subject to corrective actions, including the requirement that they reprocess previously denied claims, that they make plan design modifications, and that they notify participants of the non-compliance. Okay, so that was pretty much the picture up until 2001. Then we all of a sudden had the CAA. And very quickly, plans were hit with new documentation, analysis, and reporting requirements. So the CAA, which was passed in December of 2020, requires group health plans and health insurance issuers to make available to the DOL, Treasury, and the HHS, upon request, a written NQTL comparative analysis. So prior to this time, plans, had the self-assessment tool. They could perform a sort of in-depth or deep dive NQTL analysis if they wanted to, in order to mitigate risk of lawsuits or potential DOL investigations, but there was no real requirement that they maintain a written analysis. Now, all of a sudden, plans have to do that. And that went into effect February 10th of 2021. The comparative analysis has to address the specific plan or coverage terms or any other relevant terms related to NQTLs applied under the plan, a description of all mental health and substance use disorder and medical and surgical benefits that each NQTL applies to in each benefit classification. So if we think back to that, inpatient, in-network, outpatient, in-network, those 6 classifications, that's where that comes into play here. The analysis also has to address the factors and evidentiary standards used to determine that the NQTL will apply to mental health substance use disorder versus medical surgical benefits. And it must include a detailed comparative analysis demonstrating that the processes, strategies, evidentiary standards, and other factors used in applying the NQTLs were used comparably and no more stringently with respect to mental health and substance use disorder and medical surgical benefits. Again, when doing these comparative analyses, you have to compare benefits within the same classification, and you have to do an as written and as applied or in operation analysis. And then the analysis also has to include specific findings and conclusions reached by the plan, including any results of the underlying analyses that indicate that the plan is or is not in compliance. So we have a new enforcement mandate under the CAA related to that written analyses. The departments are actually required under the CAA to request at least 20 NQTL analyses from plans and issuers per year. What we've seen and what we'll talk about in the moment is that the departments actually are requesting way more than 20. This is definitely an enforcement priority for them. And I don't expect that this is going to slow down anytime soon. So general timeline, the DOL requests the information. The plan has a short period of time to provide the analysis, and we'll get into detail about our experiences related to the timeline when we get into practical experiences. The DOL basically can make an initial determination of noncompliance. It can also make an initial determination that the reporting or the analyses was insufficient, and either request updated analyses, or if there's been an initial determination of noncompliance, it will request the plan to submit updated analyses and or proposed corrective actions. And then the DOL will consider the updated analyses and propose corrective actions. And if the DOL makes a final determination of noncompliance, then the plan has to notify covered individuals of the noncompliance within 7 days. So again, thinking back to those penalties, if you are required as a plan to notify all of your participants that you're not in compliance, that's going to increase your litigation risk. All right, so we did get some guidance shortly after the effective date of the CAA. For analyses to be considered sufficient, it has to contain a detailed, written, and reasoned explanation of the specific plan terms and practices at issue. and has to include the bases for the conclusion of compliance or non-compliance. So really, you know, what the DOL has kind of communicated again and again is that it's not sufficient to just sort of provide blanket conclusions. We're in compliance, we're not in compliance. It's not sufficient to, you know, just provide lists of factors that were considered. You have to actually engage in a detailed analysis of why those factors were considered, how they were considered, what differences there may have been between applying those considerations in the mental health context versus medical surgical, and why those differences came into play. And the DOL did say that plans that carefully apply the DOL self-compliance tool that's been around for a while should be in a strong position to comply. I think that's questionable based on what we'll see in a moment. But that is at least the DOL's opinion. So in the guidance that we got, the ACA FAQs Part 45, we did get some additional, I guess, some clarity on what the DOL is looking for. So again, they're looking for a clear description of specific NQTLs, plan terms, policies. They want a specific identification of all of the benefits to which the NQTL applies in each classification. They're looking for detailed analyses, basically. And so when we get into how this is applied, you know, so if they're looking for a reasoned discussion of the plan's findings and conclusions as to the comparability of processes, well, what does reasoned discussion mean? And what kind of detail are they looking for in that reasoned discussion? So one of the biggest questions that continues to hang over our head is, you know, what level of analyses will the DOL consider to be sufficient? And we still don't have a clear picture of that. Okay. We do know from the FAQs Part 45 that the analyses also must be accompanied by supporting documentation. The records documenting NQTL processes and detailing how the NQTLs are being applied, any documentation including guidelines, claims processing policies and procedures, or other standards that the plan is relying on in conducting their analyses of the NQTL. And we know that when providing this supporting documentation, it's not enough to just sort of hand over a dump of documents to the DOL. You have to explain, you know, what the supporting documentation actually supports, and how the supporting documentation was used, and how the DOL should be looking at that supporting documentation. All right, going forward. Okay, and so we did get some examples of what not to do from this guidance as well. So again, a general statement of compliance, conclusory references to broadly stated processes, those types of things will be insufficient. Avoid production of a large volume of documents without clear explanation as to how they apply, and other tips on what to avoid. Analysis that's outdated due to passage of time, that's a big one. All right, focus of the DOL's requests for disclosure. So according to the FAQs, the DOL's expected focus was going to be on prior authorization requirements, concurrent review, standards for provider admission to participate in networks, and then provider reimbursement rates, out-of-network reimbursement rates. But just because we're getting some ideas of what the DOL is focused on, that doesn't mean that plans should only be focused on analyzing those types of NQTLs. Plans really need to be looking at all of the NQTLs that they're applying, because the DOL may, and in fact has requested analyses for other NQTLs. In some cases, they may be requesting analyses for NQTLs that might be, surprising, or in some cases, we've seen that they're asking for analyses related to standards that the plan maybe didn't think was an NQTL. So it's important to go through and identify what are all of the NQTLs, what potentially could be seen as an NQTL. Okay, new reporting mandate. The departments themselves have to submit an annual report to Congress addressing basically what their experience has been with respect to enforcement. The key here is that if the agencies have found plans or issuers not to be in compliance, they basically have to name those plans or issuers in the report, give the reason for the finding of non-compliance and the steps they're requiring the plan or issuer to take to be compliant. So when we think back to the penalties again, and we think back to the fact that right now one of the biggest sticks is lawsuits and litigation risk. Here we have a report to Congress that's going to be produced annually that's essentially going to name and shame any plan that's found to be non-compliant. That is basically just raising a huge red flag for plaintiffs' attorneys. And so there is a big incentive at this point for plans to do the best job that they can to try to be in compliance with Mapia, to try to make sure that they're producing sufficient, if possible, reporting to the DOL and to work with the DOL to avoid that final finding of non-compliance. We are expecting more guidance this summer and later this year, so hopefully we'll get some additional information with that guidance. Okay, so turning now to practical experience, and this is where I'm gonna really lean on Nicole to kind of give us the experience that Willis Towers Watson has had with respect to dealing with these reports. So we did get some information from the 2022 report to Congress that was issued earlier this year regarding enforcement actions. We know from that report that the DOL issued 156 requests for analyses. Again, more than that 20 that they were required to request. None of the responses were sufficient upon first receipt. So what does that tell us? I mean, to me, that tells us that we need more guidance from the DOL, because people, the people who I work with, the plans who I work with, they're trying to provide compliant responses. People are spending a lot of time on this. People are spending a lot of money on this. And the fact that we're spending so many resources on this and still none of the responses were sufficient should indicate that maybe we're not getting sufficient guidance from the DOL as to what's expected. There were 80 insufficiency letters issued, 30 initial determination of non-compliance, 19 plans submitted corrective action, and 26 plans and issuers have agreed to implement prospective changes to plans. So Nicole, these are some of the questions that we often get related to the enforcement rollout. What has your experience been with respect to receiving requests from the DOL, assisting plans in maybe negotiating for extensions, things of that nature?
Hey, Beth, yeah, I think you're spot on in all of your comments. And I think kind of in terms of some of these asks, there's a lot of critical information to share. So from my perspective, I think we started to really see a lot of these DOL letters go out at some point in April of last year. And what we initially saw is that the requests were divided into two parts. Part one, you were given a 10-day period to respond to, and it's specifically focused on perhaps one or two NQTLs. And likely these NQTLs seem to have been driven by a participant complaint because they did seem to be focused on a particular area. So for example, if ABA coverage was not provided, but autism spectrum disorder services were under the plan, that seemed to be something that we saw a lot of specifics on for part one. Part 2 then gave an additional 10 days for the plan to respond. So in total, it was 20 days to produce this voluminous amount of both responses and documentation supporting. And as part of these requests, we also saw that the Department of Labor was asking for operational data to truly demonstrate the compliance, to your point. So that was perhaps one of the areas that was even most tricky to get our hands on from our experience, because just navigating all of the different TPAs to figure out, okay, how operationally to support that the plan was demonstrating compliance. And with all of these initial asks that we saw with the Department of Labor, I would say WTW experienced that many were not granted extensions. So when they would ask, they would be told by the specific investigator that they were truly locked into a 20-day time frame. So you can imagine that if you didn't have anything in place and ready to go and have a comparative analysis generated, that really was a challenge to get something put together within that 20 days. Now, as time went on, we did see occasionally extensions granted. So I think it perhaps depended on the investigator and the situation, but it's definitely been an area where I think the term aggressive is probably something we could say and was maybe a bit unusual on the health and welfare front.
Yeah, and I think the DOL has, they have kind of taken a hardline position on this. I think their feeling is that, look, these standards have been around for a long time, even if the reporting requirement or the written analysis requirement has not been around for a long time. And their feeling is, we've given you this self-assessment tool, plans, had what they needed to be able to do these analyses, and plans should have already been, doing, if not documenting to the level required now by the DOL, these types of analyses. And so it's been very difficult to, sort of get the DOL to understand that there are issues in practice. And I think a big one is sort of negotiating and dealing with cooperation of the TPAs that would potentially prevent plan sponsors from being able to do these deep dives. So getting back to your comments about scope, Nicole, let's see. So you talked about the part 1 and part 2 of the requests. And we do have some information from the 2022 report to Congress about the top types of NQTL that they're requesting analyses for. In your experience, when you get to that part 2 of the request, is the DOL still, identifying specific NQTLs, maybe a broader list, but specific NQTLs still that they're looking for? Or are they at that point essentially saying, just give us your full analyses for all NQTLs under the plan?
Yeah, really good question, Beth. So I think they are still generally just asking for a comprehensive list, to your point. One thing we did start to see this year, and we haven't seen quite as many requests rolled out, and I guess, obviously we're still in April, so not to say that's not going to happen. But something that we've seen this year that was interesting is we did have a couple of self-funded plan sponsors that we work with that received a request asking for what changes they made as a result of the comparative analysis that they completed.
Oh, interesting.
So they didn't actually ask for everything. They wanted to get a sense of, okay, what were the changes as a result? And I thought that was interesting, and just wondering if perhaps the Department of Labor is getting sick of receiving all of the analyses that they clearly don't like, but not really giving us any guidance as to what they're looking for. So I thought that was an interesting take on kind of a spin on what they've been doing. But to your point, really, I think they've lasered in on particular requests where they've said, okay, and they want to laser in on a specific NQTL, but then they do ask as a catch-all, please also provide a comprehensive list of the analysis.
Okay. And have you seen any sort of outliers or anything that's been surprising other than what you just mentioned as far as types of NQTLs that they seem to be focusing on?
No, I think all of what we've seen is really listed on this
Okay.
list. It's all been captured here. And so I think that is the list, the extensive list of what we've seen. And obviously, you know, we've probably seen about 25 of these. We haven't seen all of them. But they really do seem to be generated, though, by participant complaints. I do know that recently the Department of Labor subpoenaed the national carriers and asked them to provide a list of some of the self-funded clients that did not cover ABA therapy, for example. And then it seems as though they were going to specifically reach out to the self-funded plans to perhaps audit them.
Okay.
So that was interesting in terms of the approach. And I know they did some of that last year as well.
Yeah, and that's in line with what they indicated in the 2022 report to Congress. Mm-hmm. They basically said that for the most part, they were selecting plans to request analysis from based on existing investigations, not necessarily into that plan, but potentially into a service provider who administers benefits for that plan.
And that makes sense. And I guess from your perspective, is that more of a jurisdictional issue, right? Because they primarily have the jurisdiction over the self-funded plans.
Yep. Yeah, and so it seems that, you know, one of the ways that they're potentially trying to force change within the service providers is to go after the plan sponsors who they have direct enforcement authority over, and then with the hope that those plan sponsors will, you know, push service providers to perhaps focus more specifically on certain types of NQTLs and changing common practices related to those NQTLs. All right, so as I mentioned, none of the initial responses were sufficient. The DOL did indicate that with respect to a lot of the early requests, many plan sponsors were unprepared. Some plan sponsors thought it was the TPA's responsibility. They hadn't done analyses, and the DOL, as I said, is pretty unsympathetic at this point to those responses. Now, what we know in practice and what we see is that, you know, yes, this isn't directly the TPA's responsibility. The responsibility, particularly with respect to self-insured plans, lies on the plan sponsor. However, when we look at all of the information that's required to actually complete the analyses into the NQTLs, who has all of that information, right? It's the TPA. The plan sponsor generally isn't the one designing these NQTLs. They're not the one making decisions about which benefits to apply the NQTLs to. They're not the ones listening to medical experts or exploring medical journals. They pay their TPAs to do that and to develop these medical management standards for them. And the TPAs have most of that information. They've got the information that would be needed to, for example, do an as applied compliance review, because they have all of the claims data. They have information about what their internal practices are. So, you know, even identifying NQTLs, we can take a look at the benefit booklet that's provided by the TPA and identify certain NQTLs that are called out in those booklets. So for example, oftentimes those booklets discuss pre-certification or pre-authorization requirements, maybe fail first or step therapy requirements, but we won't always necessarily be able to identify every NQTL just by going through a benefit booklet. There may be NQTLs that are applied as part of the TPA's standard processes and procedures for claims processing that we don't have, you know, a very apparent view into. And so we really have to rely on the TPAs and cooperate with the TPAs and seek whatever support we can from them to get the information needed for this analysis. And I think, unfortunately, there is sort of still a disconnect between the TPAs and a lot of plan sponsors, as far as the TPAs thinking, well, this is really plan sponsor responsibility, and maybe not understanding that the plan sponsors, you know, don't have the information that they need in order to do these analyses. So with respect to, you know, TPA involvement, Nicole, what has your experience been in working with the TPAs and in requesting the information, not only to identify NQTLs, but you know, the factors that went into those NQTLs, and then the info needed for as applied analyses?
Yeah, well, I think as you can expect, there's definitely been a gamut, right? So there's been different experiences depending on who the TPAs is. One thing I can say though is I think, as with all of us, there's been a general confusion as to specifically what the ultimate ask is and what needs to be produced. And so I think the good news is, as we all learn what's being asked through some of the DOL submissions, the TPAs that are getting the experience are really evolving in terms of what they're able to support and provide and support. I would say for the most part, a lot of the TPAs have taken the position that this is the responsibility of the plan sponsor, and they are somewhat limited in what they'll do. So they're not necessarily willing to complete a comparative analysis on behalf of the plan sponsor. And I think that's put a lot of our clients in a really challenging position because, again, to your point, Beth, who owns the clinical policies and who puts them together? It truly is the TPAs, and I think that's where it's been so challenging. And so on a recent webinar with the Department of Labor, they used the term finger pointing, and so they took the position that it's both plan sponsors and TPAs pointing fingers at each other. And ultimately, I think we need to get to a place where there is the synergy, where there is the ability to work together to get the Department of Labor what they need, because truly it is a team effort. The other thing I would say with the TPAs is whenever you ask them for their findings, they're all going to say that they have no issues, right? They're all saying that they're meeting all of the requirements with Mapia. And that's my fear when you use a TPA, even one that's willing to do the analysis on behalf of a self-funded client. It's just they're not going to identify any issues. And I can say that WTW, as we've worked through with our team, we've definitely identified issues with a large number of the TPAs. And so I think that's where so much of this is clinical in nature, right? It's not just something that with a legal background you could put together. It truly has such a clinical tie. And so it really does take the TPAs and clinicians to work through this with the help of attorneys.
Yes, yeah, that's a great point. So this is something that requires multiple points of expertise. And I completely agree. To the extent that we can get to a place of greater cooperation, I think it will be in everybody's best interest, because you know the TPAs unfortunately are getting sued over some of these practices as well. And you know, everybody is kind of living in this gray area right now where we don't really have the clearest of guidance, and we're trying to push through this. It's interesting, you know, when we look at these gaps in analyses that the DOL identified in that 2022 report to Congress. I mean, some of these are, you know, in line with maybe what you would expect, but some of them are kind of surprising. So, for example, that plans failed to document comparative analyses before designing and applying the NQTL. Well, I mean, I was pretty shocked when I saw that called out, because for the most part, a lot of these NQTLs have been applied by plans for years, before the requirement, long before the requirement existed to document comparative analyses. And so, it's kind of, I'm not sure, what the DOL is expecting with respect to NQTLs that may have been in place, for decades. And again, oh, sorry, go ahead, Nicole.
Oh, no, and Beth, I just wanted to chime in too. It's almost like who is reviewing at the Department of Labor.
Exactly.
So, do they have the clinical expertise to even dive into some of this? I don't know. When I've looked at some of the insufficiency letters that have come back, it's almost like some of it was just blanketed and copied, and it just didn't necessarily align with what I think was submitted. So that's a concern as well. I think you're spot on. I don't necessarily think, I think a lot of this is in place and there may be a failure to understand what they're looking at.
Yes, and it's unfortunate, because I think a lot of this is coming from the best of intentions, but when we get into actually applying it, it is, very difficult to apply on all sides. And because of the level of expertise that's involved in developing and applying these limitations, it's not something that, just an attorney alone could pick up and evaluate, for example. All right, moving on. Let's see, every time there we go. Okay, so top NQTLs that were implicated in non-compliance findings. We see limitations and exclusions on ABA therapy. Like Nicole mentioned, a lot of plans were being targeted for this based on information that was received through investigations of service providers. They also focused on billing requirements. So requirements, for example, that licensed mental health or substance use disorder providers can only bill the plan through specific types of other providers. Limit or exclusion of medication-assisted treatment for opioid use disorder. That has been an issue that actually has been called out for several years now in the guidance as a red flag. Pre-authorization or pre-certification requirements that are applied in a non-comparable manner. Limitation or exclusion of nutritional counseling for mental health substance use disorder conditions. Oftentimes that relates to eating disorder treatment. And then several other top NQTLs, and more are identified in that 2022 report to Congress. Okay, so lessons for plan sponsors. Preparation is key. So you should not be waiting for the DOL to request the analyses to start reviewing your Mapia compliance. What we know is that the DOL has already said, if you're waiting for a request from us, that's not sufficient. So already that's a first failure there. Cooperation of TPAs and insurers is necessary. But plan sponsors have to take an active role in requesting and reviewing the analyses. So what we've seen is that, the first time you ask, you're probably not going to get the best response. You have to keep asking. You have to keep requesting the information and support that you need. And we'll go over a checklist in a minute that gets into greater detail about what you should be requesting. Certain NQTLs are highly likely to be non-compliant at this point. So basically, if you cover autism, but you have an ABA therapy exclusion, that's highly likely to be non-compliant. Any blanket certification requirements for all mental health or substance use disorder benefits, again, going to be really difficult to justify that. And some of these NQTLs have been repeatedly cited in the guidance that's been issued by the DOL. All right, so path toward compliance, so recommended action items. So at the end of these slides, and I have seen some questions about, you know, will you get these slides? Are they going to be available to print off? I believe a link to the slides. Well, I thought it might have been included in the invitation, but actually now that I think about it, no, they probably were not. But you will get a link to the slides when the recording is sent out, I believe, and I'll check on that. But if anybody wants a copy of the slides and does not get a link, please feel free to contact me. All right, so compliance checklist. So first thing you should do is just identify all the TPAs or insurers who are administering benefits under the plan. Don't forget carve-outs. So a lot of times people focus on major medical and maybe don't think about the fact that they've got a prescription drug carve-out being administered by a PBM. Some plans have behavioral health carve-outs. There could be other types of carve-outs like telemedicine that is being offered under the plan but being administered by a TPA that's different from the main TPA administering medical benefits. So consider all of those administrators. Another thing that you can do, just, you know, sort of on your own without input from the service providers initially, is just a red flag review. So, you know, take a look at those benefit booklets. Use the DOL self-compliance tool, which identifies a number of red flags. There are also examples and red flags that are identified in numerous other guidance that is posted on that central DOL website for Mapia. And you can kind of go through and review your plan and see, oh, you know, we impose this pre-authorization requirement on, you know, mental health counseling, or this type of medication that's most commonly used in connection with mental health treatment. Does that potentially violate Mapia? And to the extent that you can even recognize those red flags, then you can know sort of maybe where to focus on digging further for additional information. Oh, and then we did not talk about quantitative treatment limitation analysis, but we do recommend that you perform that analysis. There are pretty good instructions or guidance in the self-assessment tool for performing that analysis. And you know, I know that Willis has helped clients perform that analysis. We have assisted in reviewing quantitative treatment limitation analysis. A lot of the TPAs will provide that analysis for you, potentially for a fee, but that is definitely something to keep in mind. And then when we get into performing the non-quantitative treatment analysis, which was the focus of today's presentation, again, you want to identify all the NQTLs by the plan, or applied by the plan. Ask the TPA to identify those NQTLs for you. They most likely are going to come back and say they can't identify all NQTLs for you, but they'll give you a list of all of their standard NQTLs and analyses for their standard NQTLs. The key there is that then you're going to need assistance from the TPA to identify any non-standard NQTLs that TPA might be applying for you. So where has the plan made decisions to deviate from the TPA's standard practices over the past several years? And you know, this may not always be on your radar, because you may have gotten an email 5 years ago that said, you know, TPA X is changing their standard practice to this new procedure come next year. Do you want to stick with old procedure or change to new procedure? And maybe at the time you thought you'd stick with old procedure. Well, all of a sudden you're no longer applying the TPA standard, and you may have completely forgotten about that 4 years down the road. So you need assistance from the TPA or the insurer to identify where there might be deviations from their standard plan that they are applying for you. And then additionally, determine what additional support the TPA will provide with respect to comparative analysis. Again, this is likely going to take some back and forth negotiation to determine what they can provide. If they do give you analyses, you're going to have to review the analyses to make sure that it's actually sufficient, that it meets the content requirements, at least as we think they, think the DOL is expecting them under FAQ Part 45. Did the TPA do an as applied analyses for their standard analyses, or did they only analyze, or did they analyze the NQTL only as written? Was supporting documentation provided? If not, you'll want to request that documentation. And then if the TPA insurer will not provide sufficient assistance, there are other options available. For example, Nicole has vast experience. Willis Towers Watson has been assisting their clients in conducting these analyses. We assist clients in reviewing analyses. There are third parties out there who can assist. And we are at the 1 o'clock time frame. If there are any questions that came in that we did not get to answer, we'll try to follow up via email. Nicole, any final comments that you want to make?
No, I think this was very comprehensive, and thanks for the invite. I think we'll all continue to be seeing more and more in this, given the focus of the Department of Labor.
Yep, I'll be looking forward to that additional guidance that's coming this year.
Yes.
So, yeah. All right. Our next webinar will be Wednesday, May 25th from noon to 1 p.m. We'll be looking at the CAA's new plan transparency requirements. And then I guess the final is just thank you very much, Nicole, for participating today. We really appreciate all of your insight. I think it's very valuable. And as I mentioned, we'll send a recording of today's webinar and a copy of the slides. If anybody does have any follow-up questions or wants to talk about this, I'm always happy to kind of chat. Please feel free to reach out to me. And I hope that you will attend our upcoming CAA webinars, because I think they will provide some excellent information about price transparency and other CAA issues. So thanks very much, everyone. Enjoy the rest of your day, and hopefully we didn't scare you too badly.